The basic physics involving the development of the lasers has been covered in part 1 of the series. So those who are interested, please check it out. Here, part 2 covers parameters, the properties, and the tissue interactions of the laser technology using the CO2 laser in the ear, nose, and throat surgery. This part covers surgical demonstrations and viewer discretion is advised. This original video recording tells the story of the evolution of the CO2 laser in ENT surgery in the UK in 1982, from theory to surgical, by Vasant Oswal, consultant emeritus ENT and head and neck surgeon, James Cook University Hospital, Cleveland, England. My name is Vasant Oswal. I went into medicine in 1955 when penicillin was just being introduced. I qualified in 1960, and after doing post-graduation in India and in England, I was appointed consultant ENT surgeon at the North Riding Infirmary in Middlesbrough on the northeast of England in 1970. In the 70s, the orofacial-maxillary surgery as a discipline did not exist. So I did all the head and neck cancer surgery. That included ethmoidectomies, maxillectomies, mandibulectomies, commandos, laryngectomies, block dissections, and so on. Following laryngectomy, the patient loses his voice. It has an effect on his family and his working conditions. I decided to establish a supporting team, a concept of a team approach to the laryngeal cancer was developed. The team included speech therapist, physiotherapist, patient general practitioner, works medical doctor, works manager, and many other professionals such as radiotherapist, pathologist, those who were involved in the patient management both before the surgery and after surgery were consulted. We formed a team and called it a team concept of laryngeal cancer. This concept was presented in a form of a tape slide program during the Centennial World Conference on Laryngeal Cancer in Toronto in 1974. It won an award of Best Presentation in the World. This concept now is called multidisciplinary team concept. It is humbling for me to know that I had this concept practicing in my department way back in 1974. With my advanced cancer surgery, our department came into prominence. Scottish doctors were asked to rotate with us during their training programs before they were appointed as consultants. I always been interested in teaching. I dissected temporal bones and color coded the various structures to identify them. These specimens were published in a color atlas of human anatomy in 1974. These specimens are now in the Royal College of Surgeons of England Museum. Numerous ENT surgeons have learned the intricate anatomy of the ear from these specimens, which is so rewarding for me. My interest in laser goes back to the 70s. In the early 70s, there were a few prototypes exhibited in various conferences. During IFOS conference of World ENT Surgeons in Budapest in 1981, coherent 450 model was demonstrated in the exhibition area. I tried, it was fascinating. A beam without a handle burned the surface of the apple and vaporized it. I was impressed. I decided that I should get a machine for our ENT department in Middlesbrough. So I asked the hospital authorities to fund the machine. But you know, of course, how short the money supply is in the NHS. So I decided to raise the money by public appeal. And to my surprise, I had £72,000 in 6 months. We only needed £40,000. The first coherence CO2 laser, Model 400, did not have a delivery arm, which meant that the laser tube had to be aligned with the target, which made it very cumbersome to use. Coherent 450 model with articulated delivery arm was installed at the ENT department of North Riding Infirmary in Middlesbrough in 1982. This was the first such machine in the UK. It was easy to get the machine, easy to get the machine, money as well. But what to do with the laser? There were no books, no courses, no literature. So I had to teach myself how to use the laser. Laser stands for light amplification by stimulated emission of radiation. Laser is therefore light. It is, of course, a concentrated form of light, but is still light. Since a laser is a form of light, let's first define light as we understand it. The sun emits electromagnetic radiation across the entire spectrum, but human eyes are sensitive only to wavelengths between 400 and 700 nanometers, and we call them as visible spectrum. When light reaches the retina, it stimulates photoreceptor cells, rods, and cones. They convert light into electrical signals which are conducted by the optic nerve and send them to the brain. This is how we see the world. When the entire visible range enters our eyes simultaneously, we perceive it as white light. However, if the white light strikes atmospheric droplets or any other object, it breaks into component wavelengths which we perceive as many of the colors of the rainbow. Some of them are absorbed by the object, while others are reflected, refracted, or scattered. If these components' wavelengths enter our eyes, we perceive them as colors. For instance, atmospheric particles predominantly scatter shorter wavelengths, such as blue and violet, which is why the sky appears blue. Although our ability to see emissions is restricted to the visible spectrum, many animals can detect ultraviolet emissions that are beyond our range. For instance, blue flowers often display vibrant UV patterns that are invisible to us, yet these patterns help guide pollinators like birds and bees in their foraging and mating activities, as they are capable of perceiving ultraviolet light. Let us understand and study the parameters and properties of light. Let's define some common terms used to express the various parameters of laser light. However, it's important to note that in isolation, they mean very little to understand the laser action on tissue. The eventual tissue effect depends on how a particular tissue interacts with the laser energy, as described later. We now study the waves under two headings. The parameters of light describe its numerical or other measurable factors. The properties describe the various ways in which the light behaves when it interacts with matter. The parameters are wavelength, amplitude, frequency, energy, period, and speed. Whereas properties are absorption, reflection, scatter, refraction, diffraction, and transmission. A wave is represented as a sine wave. The wavelength is the distance between two identical points. Amplitude is a vertical excursion from direction of propagation, and frequency is the number of oscillations per second. In 1917, Albert Einstein established the theoretical foundation of lasers with its concept of stimulated emission of radiation. But what exactly is being stimulated and by what mechanism? Light travels as electromagnetic radiation. It travels in a wave form, but it also contains little packets of energy called quanta. Quanta carry energy in light. They're also known as photons. When an electron spinning at a ground level is energized, it jumps to a higher energy level. Here, it is unstable. It therefore emits its energy as a photon and decays to a stable ground level. This type of emission is known as spontaneous emission. But if an electron, already at a higher energy level, is further energized, it jumps to an even higher energy level. It emits one photon and also an additional identical photon. The two photons are in phase and have the same directionality and polarization. This type of emission is known as stimulated emission. Stimulated emission forms the basis of the generation of the laser beam. The laser consists of an external energy source, a laser medium, and an optical resonator. The main component of the laser is a gain medium. It is also known as an active medium since it can achieve population inversion where enough atoms or molecules are in an excited state to allow stimulated emission to dominate. The optical resonator is a cavity which consists of a pair of highly reflective mirrors placed parallel to each other at the ends of an active medium. The light bounces back and forth between those two mirrors, gaining intensity with each pass through the game medium. When a certain threshold is reached, where number of electrons and atoms in the upper energy level exceed those in the lower energy level, a state of population inversion is achieved. Population inversion is a prerequisite for the generation of a laser beam. One mirror is fully reflective, whereas the other is partially reflective. It allows a small amount of light to escape from the cavity. This is the laser beam. Laser light has some unique properties. Laser light is coherent, meaning all those individual waves are in step or in phase with one another at every single point. The laser light is collimated, meaning all the waves in the beam travel in the same direction. And the laser light is highly monochromatic, meaning it is made of one single color or a very narrow range of wavelength of that color. Although Albert Einstein theorized the concept of lasers in 1917, it wasn't until 1960 that the first working laser was built by Theodore Maiman using a ruby crystal as its active medium. This marked the transition from theory to reality. A year later, in 1961, Charles Campbell demonstrated the medical potential of lasers by successfully removing an angioma in the retina, indeed a milestone in the use of lasers. So, how were the medical lasers named? When energy is applied to a material, it emits radiation at specific wavelengths within the electromagnetic spectrum. In lasers, the emitted wavelength is determined by the lasing medium, which gives the laser a specific name. For example, a lasing medium such as a CO2 gas emits useful radiation for a variety of applications. Such a laser is therefore named a CO2 laser. We have various lasers that emit both visible and invisible light. Visible lasers are less harmful as we can see and avoid them. Invisible lasers, however, pose more danger because we cannot see or protect ourselves from them. Only a small part of the electromagnetic spectrum is visible to our eyes. We call this part a visible light or simply light. The visible range lies between 400 nanometers and 700 nanometers. When the light in this range enters our eyes, it's converted into visual information through the interaction of the eyes and the brain. Thus, lasers within this wavelength range are classified as visible lasers. Here is an example of a laser that emits within the visible spectrum. The KTP laser emits at 532 nanometer, which falls within the visible range of 400 to 700 nanometers, appearing as green light. Its optical emission aligns with the optical property of silica, which is between 600 and 2000 nanometers. The KTP laser wavelength is therefore fiber transmissible. In this image, its path through the optical fiber is clearly visible. The laser also illuminates surrounding objects, causing them to glow green. The KTP laser is being used here for tonsillectomy. After reading a little bit of theory of light, I was now ready to use the laser. I formed a team with the operating technicians of the theater. They were most helpful. They stayed behind after a day's work and we did experimentation in the evening. Carbon dioxide laser needed a constant supply of carbon dioxide gas from a cylinder. The articulated arm delivery enabled us to couple it to the operating microscope, increasing its mobility and delivery tremendously. We got the laser, we attached the video camera and the operating microscope, got a piece of steak from the butcher's, and I fired the laser beam on its surface. It was an amazing experience. The beam burned the surface of the steak and produced smoke. This was our very first experience of using the laser and see the effects. Let's have a look at the differences between the surgery with cold instrumentation and the laser. The laser lacks the carrier handle, thus there is no tactile feedback. The laser spot may be visible or invisible. Invisible lasers are made visible by superimposing a path with a visible laser such as the helium neon laser. The helium neon laser serves only as a guide where the invisible laser is going to strike. It does not indicate the extent of the tissue damage. Just as the knives come in different sizes and shapes, the lasers also come in a variety of wavelengths for specific surgical procedures. When using a knife, the depth of the cut can be controlled by using mechanical force. However, the depth of the laser cut is determined by the extent of its absorption by the tissue which interacts with the laser energy to produce intense heat. The heat not only destroys the tissue by vaporization, it also shrivels the surrounding tissue. The shriveled tissue occludes small sized blood vessels. The laser surgery is thus mostly bloodless, needing ligation only for a few large sized blood vessels. Most laser wounds do not need stitching since they are covered with coagulated tissue which acts as a biological dressing. Let's define some common terms used to express the various parameters of laser light. However, it's important to note that in isolation they mean very little to understand the laser action on tissue. The eventual tissue effect depends on how a particular tissue interacts with the laser energy, as described later. Laser power comes from excited photons which escape through the laser aperture to form a laser beam. The power of the beam is measured in watts per second. For instance, our machine was rated at 40 watts, meaning it emits 40 watts of energy every second. Energy is measured in joules and is calculated by multiplying power in watts by time in second. Pulse width is an important measure. Pulse width refers to the duration of energy delivery. It is synonymous with the time during which the tissue is exposed to the laser energy. It's usually expressed as exposure time, defined as the time elapsed between the leading edge and the trailing edge of a single pulse. Repetition rate indicates the number of pulses delivered in 1 second. Pulse widths shorter than 1 second are measured in fractions of a second. This table shows the terminology for pulse widths less than 1 second. The beam diameter is measured at the laser aperture. It was a factory specification and not a user control parameter. The beam diameter at the laser aperture of our CO2 laser 450 model in 1982 was 700 microns. Since the collimated beam showed minimal divergence at typical operating distances of 12 to 15 inches, the 700 micron beam diameter resulted in a spot size of 700 microns, much larger than the current spot size of 250 microns in most machines. As we have seen, the CO2 laser emits light at a wavelength of 10,600 nanometers, which is invisible to the human eye. Therefore, a visible helium neon laser, commonly used in laser pointers, is aligned with the path of the CO2 beam and appears as a red spot. It is not commonly appreciated that the Heine spot size is much smaller than the CO2 spot size. Using the Heine spot to judge the extent of tissue damage by the CO2 spot is erroneous. The Heine spot merely indicates where the CO2 laser beam will strike when activated. It cannot indicate the eventual tissue damage caused by the activated CO2 laser spot. The machine needed to be checked before each operating session to ensure performance. The alignment of the visible and invisible beams could be lost while moving the laser machine. We check the alignment before every operating session by firing the laser on a wooden spatula. Power output may also suffer through use. We devised a simple method to check the output periodically using a plastic block and a controlled shot. If the power output dropped below 70 mark, manufacturers needed to service the machine. Lasers that emit both visible and invisible light. Visible lasers are less harmful as we can see and avoid them. Invisible lasers, however, pose more danger because we cannot see or protect ourselves from them. The distinction between visible and invisible lasers is important for the safe use of the lasers. Visible lasers trigger an immediate blink response when directed at our eyes. Invisible laser, being invisible, cannot trigger a blink response. The blink response causes the upper eyelid to close within 1/10 of a second. It also causes the non-exposed eye to close within 290 milliseconds, and the eyeball retracts into the socket. If a laser's power exceeds 5 milliwatts, even brief exposure can result in eye damage. Our eyes are less sensitive to blue and violet colors, resulting in a delay in the blink response. Thus, even a brief exposure may reach retina. However, the cornea and the lens absorb these wavelengths and thus offer a degree of protection from harmful effects on the retina. Invisible lasers, such as the infrared lasers, pose a greater risk since they are not visible to the human eye, and being invisible, they cannot trigger a blink response. The thermal relaxation time is a crucial parameter because it influences how quickly tissue can be destroyed. When energy is applied to a target tissue, it interacts with the tissue. The interaction converts the energy to heat. Meanwhile, since the surrounding environment is at a lower temperature, the tissue begins to release this heat and cool down. This cooling process occurs at a specific rate known as the thermal relaxation time. To ensure that the tissue temperature remains high enough for destruction, energy must be delivered at a rate that exceeds the thermal relaxation time. This principle, introduced by Anderson et al., is commonly referred to as selective photothermolysis. A more accurate measure for determining the necessary exposure time is the duration required to permanently denature the proteins within the tissue. We carried out experiments to demonstrate the emission of the Heine and the CO2 wavelengths. Wine glass is made of silica, which has an optical property between 600 nanometer and 2000 nanometers. The Heine beam emission at 650 nanometer aligns with the optical range of the silica. Therefore, the Heine beam passes through the glass without interacting with it. When it strikes the wine molecules reflect the beam's path as seen in the video. The curvature of the goblet causes the beam to converge to a focal point. Next, we position the Heine spot on the drinking glass. As seen before, the Heine beam does not interact with the glass. Then, we activated the CO2 laser by pressing the foot pedal. The CO2 beam, which emits at 10,600 nanometer, cannot pass through silica, which has an optical property of between 600 and 2000 nanometers. The CO2 laser therefore interacts with the silica in the glass, heats it, and vaporizes it, creating a crater. The Heine beam thus serves as a guide to the invisible CO2 path without interacting with the glass. The glass shattered into several small pieces due to microfractures. This experiment shows that prescription glasses made of silica do not protect against the CO2 laser exposure. Specialized eyewear is necessary to block the specific wavelength. When using CO2 laser with the microscope optics, which are made of glass, offer protection because the CO2 laser cannot penetrate glass. In contrast, visible lasers such as the KTP laser can pass through standard optics. To ensure the operator's eye safety, a specific wavelength filter is added to the microscope optics. How deep does the laser penetrate? Each laser wavelength has a specific emission spectrum. When this spectrum aligns with the optical properties of a tissue, the laser can penetrate without causing a reaction. For instance, the argon laser can travel through all the structures of the eye which have optical properties which align with its own emissions until it reaches the retina. Here, the optical properties of the retina do not align with the argon wavelength emission. At this point, the retina absorbs the argon laser energy, triggering a response that leads to scar formation. This property makes the argon laser effective for treating retinal detachment as the scarred retinal tissue helps heal the tear. In contrast, the CO2 laser wavelength cannot pass through the various structures of the eye since it is absorbed by the cornea, causing corneal opacity. We now have a clear understanding of the laser light, how the machine operates, and the characteristics of the beam profile. We also studied the tissue composition as it related to the laser technology. Now, we will explore laser light and its interaction with the tissue and its implication for the surgical application. The laser tissue interactions are not uniform since most tissues are heterogeneous. Each tissue type has unique optical properties such as absorption coefficient, scattering, reflectivity, and particle size. Absorption of the energy thus results in a range of tissue effects. Likewise, each laser type has a unique emission spectrum and varying parameters such as the wavelength, energy, pulse duration, spot size, operation mode, etc., which influence the surgical outcome. Now that we have identified the common tissue chromophores, let's take a closer look at each chromophore and the specific laser wavelengths they absorb. Understanding this will help us select the appropriate wavelength for tissues that contain a high concentration of a specific chromophore. For instance, if a tissue is particularly vascular, a shorter wavelength argon laser is the ideal choice for optimum therapeutic results. If the tissue contains melanin as a predominant chromophore, then a near-infrared laser would be appropriate. For tissues that are rich in water, like those encountered in my specialty of ENT, the mid-infrared laser, such as the CO2 laser, is a preferred option. Hence, we acquired the first CO2 laser of its kind in the UK, featuring an articulated delivery arm that connected to the operating microscope. The Nd:YAG laser emits light in the near-infrared region, which lacks a specific chromophore. This region is referred to as the optical window. Because the energy from the Nd:YAG laser is not absorbed by the tissue lacking in the chromophore, it can penetrate deeper where it scatters. This characteristic makes it useful for treating solid malignant tumors. It was now 5 weeks since we got our laser. The anticipation in the hospital and also in the town was almost palpable. When was I going to use the laser on patients? Who would be the first patient? What would be the surgery? I was confident enough now, knowing all the effects of the laser on the tissue and also its limitations. So I chose a young patient who had a fibroma on his tongue.
Well, still with things medical, leading surgeons from many parts of Britain and overseas have gathered in Cleveland this week for the country's first conference on a new field of laser surgery. Techniques being pioneered at Middlesbrough's North Riding Infirmary are attracting worldwide interest in the treatment of throat cancer. And it's all been made possible by the generosity of Cleveland people who raised nearly £70,000 in record time to pay for a revolutionary laser machine. This report from Alan Powell.
The North Riding Infirmary got its new carbon dioxide laser less than 6 months after a public appeal was launched in March of last year. It's been in use for the past 10 months, and in that time more than 100 patients have benefited from a tool that takes surgery into the 21st century.
The surgery is nearly bloodless, bloodless to the extent that there is not a red spot around during the surgery. The recovery from the surgery is very quick. The hospitalization is short. The patient after this kind of surgery can perhaps go home second day, third day. They have gone home second or third day. And this is following a major excision of the tissues in the larynx and on the tongue and the floor of the mouth. Painless. Certainly the surgery is remarkably painless after the operation. The patients hardly need any analgesics, or that's the pain-killing substances, after the operation. So the advances are both for the surgeon and for the patient.
The laser, therefore, is not a cure in itself, but a spectacular use of an intensified light beam to cut away tumours either malignant or benign. The beam can be focused to a fraction of a millimetre, literally evaporating tissue. And the aftermath is almost equally dramatic. A few weeks after the removal of a fairly large growth, only a small scar is visible.
If this tool is new, I think we should find out what exactly it does and what exactly it cannot do. Therefore, the objective of the conference is to discuss and share our experiences with people from the rest of this country or Europe and America. And at the end of the day, I hope that this particular tool will find its rightful place in the armamentarium that we have to deal cases of cancer or any other lesions in the mouth and larynx.
Does this mean that there's some resistance within the medical profession to using it?
Well, there is always a core of people who perhaps don't want to change the ideas. Perhaps they feel that it's a new technology, let me see how it develops. Yes, there's always a core. On the other hand, once they come to a conference, see the results, then perhaps they would want to go home and find, if they could find.
Here is my second patient who has a hemangioma of the tongue. Normally, I would have used cutting diathermy to excise it. The CO2 laser sealed the capillaries and small arterioles with an excellent intraoperative hemostasis, providing a clear view of the target. And the added advantage is that it does not require a carrying handle. Unlike the diathermy, the laser energy does not penetrate deep, and thus there is no postoperative edema. The CO2 laser is aptly referred to as bloodless, handless surgical knife. However, it is important to note that larger blood vessels still require conventional ligation. Having seen the remarkable results of the CO2 laser surgery on the tongue, I was now ready to tackle cancer of the tongue. This 1982 CO2 laser partial prostatectomy for tongue cancer demonstrated significant advantages over traditional methods. It resulted in minimal blood loss, as the vessels, only requiring ligation for a few larger ones. Another major advantage of using the laser was intraoperative hemostasis. It provided an excellent demarcation between the diseased and the normal tissue. I was able to suture the wound without any need for grafting. As with the first two cases, there was no postoperative pain or edema. Incredibly, all stitches came off due to the painless movement of the tongue, and to everyone's surprise, the patient could enjoy a full breakfast the next day. Since he was mobile, painless, and able to swallow, I discharged him just after a couple of days. This case highlighted that stitching or grafting is unnecessary, marking a significant advancement over traditional cold instrumentation surgery. 6 weeks review showed full recovery. There was very little fibrosis or morbidity. The tongue mobility was remarkable considering the size of the tumor. I was witnessing a paradigm shift in the surgical instrumentation. After a successful partial glossectomy, I used the laser for transoral total glossectomy. This patient developed massive lymphedema due to radiation, and she could not swallow food. As a Jehovah's Witness, the patient refused transfusion, so I ligated her lingual arteries to minimize the blood loss. Initially, there was very little bleeding due to the hemostatic property of the laser. But as I cut deeper, I came across a large blood vessel which started to bleed. It was a submental branch of the submandibular artery, which is a branch of the facial artery, and therefore lingual artery ligation was ineffective in the anterior third of the tongue. As I continued posteriorly, there was virtually no bleeding because of preoperative ligation of the lingual arteries and also the concurrent hemostasis due to shriveling of the small blood vessels. I was able to excise the whole of the tongue, including the posterior third, right up to the vallecula. The excised tongue showed massive lymphedema with very little soft tissue. She did not have any pain or swallowing postoperatively. She managed semi-solid foods and was able to vocalize sounds to form words. A follow-up 1 week post-op showed slough covering the surgical site. A review 6 weeks later showed the operation site healed with a complete mucosal covering. The swallowing was adequate and she had developed useful vocalization, a truly remarkable outcome. 1, 2, 3, 4, 5. Our CO2 laser experience showed unequivocally that laser surgery is a preferred option for treating oropharyngeal pathologies, replacing traditional methods that relied on cold instrumentation and cutting diathermy. Having operated on several patients with oral pathology, I started using the laser almost as a standard surgical tool. The time had come now to think about using the laser in the larynx. Using the laser in the larynx had obvious advantages. The beam did not need a carrier handle. The view of the operating site thus was unobstructed. Intraoperative hemostasis was another advantage. With our experience of using the laser in the oral cavity, there is very little postoperative edema after using the laser. Obvious advantage in the larynx, thus avoiding any possibility of airway obstruction. However, using the laser in the larynx was challenging. For a start, we have flammable anesthetic tubes and high oxygen concentration. A hazardous situation should a laser beam strike the tube accidentally. Well, we overcome this by designing a flexible metal anesthetic tube. The other problem was smoke. Smoke is heavier than air and it remains at the point of production. We addressed that issue by designing instruments with a hollow shaft. The shaft was connected to the suction machine and the smoke was instantly removed. So we have now solved problems using the laser in the larynx. My final concern about using the laser in the larynx was the power setting. The spread of the thermal energy to the vocal fold may cause scarring and lead to a poor vocal outcome. One day, I was watching the egg being fried. It gave me an idea. The egg white is transparent when raw and turns white when it's being cooked. So I could use the laser and see the effects of the heat of the laser on the biological tissue to see it spread not only on the surface but also deep to it because egg white is transparent. So let us study the egg white CO2 laser interaction. When the CO2 laser strikes the egg white, it interacts with water, which is its key chromophore. The water turns to steam at 100 degrees centigrade and escapes as vapor. As the water depletes, the laser energy scatters and interacts with the proteins in the egg white, generating heat and coagulating them. At 150 degrees centigrade, the coagulated material starts to burn, forming a layer of char. The char absorbs the energy and heats up, producing smoke. Further heating of char results in sparks. The hot char radiates the thermal energy in all directions, coagulating the surrounding egg white. The frame-by-frame analysis illustrates the interaction between the laser and the egg white. In the first frame, the CO2 laser energy is absorbed by its chromophore, water. This absorption causes the water to heat up, form steam, and escapes as vapor. At the same time, the solid components also heat up and create a coagulum. As the coagulum continues to heat, it burns and forms a layer of char, which radiates heat to produce more coagulum. This process continues until the exposure stops. This experiment demonstrated that there are two effects when the laser strikes the egg white. The laser absorption by the water results in vaporization and it is a specific laser effect. Then the laser energy scatters and heats up the protein, coagulating it. Further heating burns and forms char. The char radiates the thermal energy into the protein deep to it and converts it into even more coagulum. The effects of the laser are apparent on the surface, but the effects of thermal spread deep to it are not so clearly apparent. They do result in a tissue damage far more significant than the surface damage. And later on, when I started doing surgery on the laryngeal papilloma, I found the egg white effects were exactly replicated on the papilloma. Initially, there is vaporization of the water content. It is followed by charring, which is surrounded by a zone of coagulum. Egg white experiment is thus an excellent model for understanding and teaching the effects of laser spread within the solid tissue. To explore the effects of varying power settings and exposure times, I conducted a series of egg white experiments. In the first frame, 40 watts delivered over a full second resulted in a large coagulum as expected. Next, I reduced the power to 10 watts while keeping the exposure time at 1 second. The second frame reveals a smaller coagulum, but deeper tissue damage remains evident. Finally, I maintained power at 10 watts but shortened the exposure time to just zero point 0.1 second. The third frame demonstrates significantly reduced deeper tissue spread. These findings highlight that exposure time plays a far more critical role than power in minimizing the deeper spread, making it a key parameter in precision laser application.